we have another important topic which needs to be spoken more than what it is currently spoken about. And we have all the people who are my personal favorites and dear friends, Chitra, Tejaldi, Dr. Nitin, Dr. Jayashree Gopal. Looking forward to this wonderful talk, and we are going to have Chitra as the lead of the session. And Chitra is an endocrinologist, a passionate endocrinologist and a dear friend from Bangalore, dealing with hormonal conditions, whichever come to her way, in a fantastic manner. And we have been on board for a lot of things together. And over to you, Chitra. I would request you to first introduce your experts and then go ahead with the session.
Thank you so much, IDEC team, for that introduction and for the opportunity. I have 3 star experts with me today. We have Dr. Tejal Lathia. She's a consultant endocrinologist from Navi Mumbai, India, and she's my dear friend. We've been working extremely closely in the last 2 years, and like I say always, she's the find of the decade for me. The second expert that we have today is Dr. Jayashree Gopal. She's a consultant endocrinologist at Apollo Hospitals, Chennai. She's an excellent orator, and we've been running a book club for a while, and Dr. Jayashree is an active participant, apart from all the academic achievements that you can read. And she's going to take us through very important points related to bone health and diabetes today. And last but not the least, the only man on this masterclass, Dr. Nitin Kapoor. He is a professor of endocrinology at CMC Vellore, India. And today he's going to be showcasing much of the work that he's been doing in this area. And we have lots to learn from all the experts. So without much delay, let me quickly take you through why we need to have this topic and why we need to talk about another condition that you'll have to keep in mind while you're providing comprehensive care for your patients with diabetes. Can I request the host to allow me to share the screen, please? Perfect. Thank you so much. So I'm at the end of my brief introduction of about 3 minutes. You should be convinced that you should hang around in this masterclass and pay attention to why we're talking about this. Now, in the previous session, we learned about post-vaccination. We spoke about catering to mental health and anxiety issues in diabetes. And here we're talking about yet another thing that you'll need to bring up to address. And every new point that you have to address in your busy diabetes clinic is minutes taken away from your busy day. But let me provide the context by itself. Osteoporosis increases your risk of fractures. And this is just data related to hip fractures itself. After you have a hip fracture, about 40% of them are unable to walk independently after that, which means it seriously affects their quality of life. The mortality increases by about 20 to 24% in the first year after your hip fracture. About 60% of them require assistance for a year or longer, which means that caregiver burnout is going to be on the higher side. Also, maybe health expenditure. About 33% are dependent in a nursing home, and this is data from the US. But 50% of individuals who have a fracture now are at increased risk of developing another fracture within the next 1 year. So the risk of developing a second fracture is 50% higher. So it's an important factor which could affect not just mortality, also affect quality of life. And if you're trying to look at the risk of fracture in individuals with diabetes, this is the most recent systematic review and meta-analysis published in 2021, which took a look at 22 cohorts of studies, which included close to 64 lakh individuals. And what they found was that presence of diabetes, be it type 1 or type 2, increases the odds of all fractures, but specifically fractures at the hip, both type 1 and type 2. So that's the point that we're trying to get at, that this diabetes mellitus, although it is a metabolic condition, does affect bone health by itself. Now, I want you to pay a little bit of attention to this slide, which is showing you the bone mineral density difference between individuals who have type 1 and type 2. Bone mineral density is a is one of the most important tools that we use to look for osteoporosis. Lower the bone mineral density, greater your risk of fractures. If you notice in the first bar, which is type 1 diabetes, the bone mineral density is lower as compared to individuals who are controls. But if you take a look at individuals who have type 2 diabetes, be it men or women, the bone mineral density remains the same as controls. So in the previous slide, I told you that the risk of fractures is increased in individuals irrespective of the type of diabetes. But in the second slide, I'm now telling you that the bone mineral density seems to be same in individuals with type 2 diabetes, but the fracture risk is definitely increased. So which essentially means that there is some risk of fractures which is not truly captured by BMD. And that's going to be a point which we're going to speak about a little bit more and try and learn how the diagnosis of osteoporosis in individuals with diabetes might be evolving rapidly. And in the last few years, there's a lot of work that has been done. This is a slide which is trying to temporarily tell you the changes which happen to your bone mineral density with age. So all of us gain up peak bone mass by the time we reach adult life, and thereon, there is a drop in your bone mass with age. By around menopause, women see a sharp drop in bone mass, whereas men continue to lose it gradually overall. Now, the presence of diabetes does overall blunt the amount of bone mass that you have. And this is data from children who've been diagnosed with type 1 diabetes. But the point I'm trying to make is that there's a progressive loss in your bone mineral density with time, which means that the risk of fractures also increases with age. So whether it is men or women, your risk of fracture increases sharply by around 65 years of age with women, and by about 70 years in men. Now, diabetes accelerates the onset of fractures in both men and women, and we are going to talk about a potential amend to the age at which we begin screening for osteoporosis, especially in individuals with type 2 diabetes. And take a look at this graph, which is trying to show you that the prevalence of diabetes broken up according to age groups. If the prevalence of diabetes overall is about 9% or 10%, as we see individuals who are greater than 60 years of age, you see that the prevalence goes up to 20%, which means every 1 in 5 individual over the age of 60 years, be it man or woman, could have hyperglycemia. So the connection between the two are the same. Both diabetes and osteoporosis are highly prevalent. The risk of both of these conditions increase with age. Both of them are usually silent and asymptomatic unless you're actively looking for it. And both of them come with serious consequences and mortality risk increase. Diabetes by itself does contribute to osteoporosis, and that is what Dr. Tejal is trying to, will be speaking to us next. Certain complications related to diabetes like vision or loss of balance or presence of neuropathy does increase your risk of fall and fractures. We also have the thorn that we don't want to talk about, which is drugs, which are used for diabetes and their risk for fractures. So it's also important to remember all the time that osteoporosis is not just a disease that affects women, it's also something which is plaguing men as well. So with that, we'll move on now to talk about how to assess bone health in individuals with diabetes, what are the changes that we are looking at, the relationship between diabetes and osteoporosis, management strategies, and what the latest guidelines are looking like. So to discuss these important topics, I welcome our speakers. The first speaker for the day is Dr. Tejal Lathia, and she will be talking about the connection. While Dr. Tejal Lathia is sharing her screen, I'll request the audience to be typing in your queries into the chat box, and we will be taking questions at the end of the session. Over to you, Dr. Tejal.
At the outset, thank you, Dr. Neeta Deshpande, for the kind invitation. It's my first time at IDEC 2021, and it's really great because Dr. Anjali is here, who's a dear friend. And Anjali, all of our MBBS friends are actually coming to my house today, so you would be glad to know. I wish you could be here. So Chitra has set the stage by telling us why is it important to talk about this topic at all. And she's also talked about the difference in the bone health in people with type 1 diabetes and type 2 diabetes. So I know that my eyes should be on the clock, and I have roughly about 8 to 10 minutes to finish my presentation. So it is not possible for me to go into the depths of the pathophysiology of diabetes and how it impacts bone health. What I would rather do is give you an overview of what are the critical points where diabetes impacts bone health. And then Dr. Jayashree Gopal and Dr. Nitin Kapoor will tell us more practical issues of how to assess bone mineral density and how to treat it. I think this slide is very important, that we need to start thinking about skeletal deterioration as one more complication related with diabetes. All of our focus is on microvascular complications and macrovascular complications of diabetes, but skeletal deterioration as an inevitable complication of diabetes is something that we usually kind of put at the back of our mind, even though we are aware of it. So what I'm going to do is I'm going to start with my take-home message first, because that will also help me. So this is my agenda come take-home message. What we need to understand is that not only is the risk of fractures increased in people with diabetes, but also the fracture healing is delayed in people with diabetes. So there are two aspects to this, that yes, a person is more likely to get a fracture, but also that the fracture is likely to take longer to heal. The second point, which already Dr. Chitra made, and I cannot emphasize enough, is that people with type 1 diabetes have a much greater risk of a fragility fracture as compared to people with type 2 diabetes. So our type 1 diabetes patients do require extra focus, and we need to look more closely at their skeletal health. A BMD assessment underestimates the risk of fracture. And I was going to put this slide, and I'm glad that Dr. Chitra did, that if you look at the bone mineral density in people with type 2 diabetes, often the bone mineral density is normal. However, the risk of fracture is increased. In people with type 1 diabetes, there is a reduction in the bone mineral density. However, the risk of fracture is disproportionate to the reduction in bone mineral density. So increased risk of fractures, delayed fracture healing, type 1 diabetes being at greater risk as compared to type 2 diabetes, who in turn is at greater risk than the general population. BMD alone underestimates the risk of fracture. And the mechanism by which diabetes affects bone health is not only the direct effect of glycemia, but there are a lot of indirect effects we must consider. The comorbidities which are associated with diabetes, like in type 1 diabetes, you have celiac disease, rheumatoid arthritis, vitamin D deficiency, as well as the impact of the medications that we give for diabetes, which also have an impact on the bone health. Type 1 diabetes, if you look at the relative risk, there's a 5 to 6 times increased relative risk of having a fracture as compared to the general population, while the risk in type 2 diabetes is up to about 2.5 times as compared to a general population. What is very interesting is that the healing time is increased by almost 87% in somebody with diabetes as compared to somebody who does not have diabetes after a fracture. And one very important point which we often don't consider is that when there's a hip fracture in somebody with type 2 diabetes or type 1 diabetes, they're hospitalized for the same. Around this time, these people are also at a greater risk for cardiovascular events. We all know that falls have a lot to do with the risk of having a fracture. And in diabetes, we have a myriad of reasons why these people are at risk for falls, but mainly they can be divided into vision-related problems, cataract, retinopathy, hypoglycemia, blurring of vision, fall, or it could be gait and balance related problems, peripheral neuropathy, foot ulcers, frequent visits to the bathroom. An elderly patient can't rush to the bathroom, stumbles over something which is there in the night, has a fall, and then has a fracture, and delayed reflexes. However, just the bone mineral density along with the falls still does not explain the disproportionate increase in fragility fractures that people with type 2 diabetes often have. So then how do you explain it? And I think the two words which explain the entire pathophysiology is bone quality. We all talk about bone mineral content and the calcium content of the bones, the bone mineral density. We talk about all of these things very often. But there's a lot more to the bone except only that. There's a lot to do with the protein and collagen content. What is the secondary structure of this collagen? What is the microstructure of the bone? What about the bone cell activity and the dynamics? All of these things contribute to bone quality. And of course, in diabetes, because of the accumulation of advanced glycation end products, like every other tissue in the body, bone is also affected with it. And The two words which explain the pathophysiology and the impact of diabetes on bone health is bone quality. I think we're so fortunate to live in this time where this is a latest paper published from India in our premier endocrinology journal by Dr. Sanjay Pedada's group, where they've actually looked into bone biopsies, looked at the mechanical, material, and compositional determinants of human trabecular bone quality in people with type 2 diabetes. So what they did is, in a person with type 2 diabetes who has had a fracture, they've actually taken a bone biopsy and looked at the determinants of bone quality. There's a lot of complicated procedures that they subjected the patients to, which I won't go into. But what they surmised is that hyperglycemia's detrimental effect on trabecular bone quality occurs at multiple scales. And all of these together reduce the ability of the bone to absorb the impact of the fracture. So there's lower energy absorption, and the toughness of the bone is compromised in people with type 2 diabetes, which indicates an increased propensity to bone fragility. So bone quality, reduced toughness of the bone, less ability to absorb energy, and therefore the increased risk in bone fragility. It is not only the trabecular bone that is affected, but if you look at this is controls, and this is people with diabetes, and the cortical porosity is also greatly increased. And these small things, that is the trabecular bone quality, as well as the increased cortical porosity, is not captured by a simple DEXA scan. And I know Dr. Nitin Kapoor is going to talk about other ways that we can assess bone quality over and above a DEXA scan. I don't want to think that only India has the copyright on exploring with bone quality, and there's data from across the world where microindentation techniques, which look at the material strength of bones, shows that in people with type 2 diabetes, either not adjusted for BMI or adjusted for BMI, shows that the bone material strength of people with diabetes is less than that of controls. So is it just the bone quality? Is there anything else? So bone quality definitely over and above bone quantity determines the risk of fractures that people with diabetes have, as of course the risk of falls as well. Can we go just a very little bit deeper in the next 2 to 3 slides? And we look at type 1 diabetes, where of course hyperglycemia, but also hypoinsulinemia with a drop in IGF-1, which is responsible for bone turnover and increasing bone mass, is affected. Autoimmune inflammation that often accompanies people with type 1 diabetes, be it celiac disease, be it rheumatoid arthritis, or any other autoimmune condition which accompanies type 1 diabetes, will also impact the bone quality, and of course vitamin D. So ultimately in type 1 diabetes, one important point which is different than type 2 diabetes is hypoinsulinemia, which contributes along with the other factors and autoimmune inflammation. All of this together reduces bone strength and quality, impacts bone mineralization, and increases the risk of fractures. And of course, the younger the age, greater the duration of diabetes, presence of other complications requiring large doses of insulin, lower body weight, compromised renal function, all of these together over and above the lower bone mineral density that these people with type 1 diabetes has, impacts the risk of fracture. Just one last point that I wanted to make before I move on from type 1 is that, as Dr. Chitra showed a beautiful graph, that in people who have diabetes early, that's exactly like type 1 diabetes, because the hyperglycemia comes at a very early age, there's an impact on the mesenchymal stem cell proliferation, and less mesenchymal stem cells will proliferate into osteoblasts, which will impact the accrual of peak bone mass. So the point I'm trying to make here is that at the start of diabetes, people with type 1 diabetes, because if they get diabetes prior to their pubertal stage, they start out with a lower bone mass. And then obviously, as the diabetes years continue, greater and greater impact is then there on this bone mineral density, which worsens. That is why it explains that 6 times increased risk of fracture. So not only they will start with lower bone mass, but then because of diabetes, the bone mass deteriorates quicker. And the point that I already made, that the celiac disease and the rheumatoid arthritis, the lower body mass, are additional factors. In type 2 diabetes, just one point which is different, how in type 1 diabetes, lower insulin levels, lesser IGF-1 was a unique point with autoimmune disease. In type 2 diabetes, the inflammatory cytokines which are generated from our adipocytes, so the fat mass, visceral fat, generates a lot of inflammatory cytokines which have effects on the osteoblast and the osteoclast as well. if I could explain with this diagram in very short, the adipocytes, the inflammatory cytokines lead to a lot of reactive oxygen species. Now, this reactive oxygen species affect the mesenchymal stem cells. And instead of becoming osteoblasts, more and more of them become adipocytes. So what happens is the adiposity in the bone marrow also increases. Of course, there is an effect of this reactive oxygen species on osteoblasts, its ability to make collagen, its ability to respond to insulin, IGF. So this ultimately will lead to decrease in the bone turnover. And of course, vitamin D, PTH, the hyperglycemia have their own independent effects. But in type 2 diabetes, the adipocytes, greater proliferation of adipocytes in the bone marrow, lesser amount of mesenchymal stem cells, and the chronic inflammation that is there in a person with type 2 diabetes has its own unique impact on the risk of bone density. So I would like to go back to this slide, which says that basically it is the quality of the bone, the quantity of the bone, both of whom, along with the risk of falls, will increase the risk of fracture fragility. I'll just finish in the next 2-3 minutes. So one thing that we don't consider in people with type 2, when we're treating people with diabetes, is the effect of anti-diabetic drugs on bone metabolism. There are a lot of studies out there which have looked at the effect of individual drugs on bone mineral, on bone markers, and on bone mineral density, and the risk of fractures. And if I just can take your attention to the last column, in metformin, the risk of fractures does not seem to be disproportionately increased. Thiazolidinediones, especially when we're prescribing them to postmenopausal women, we have to be cognizant of the fact that they do impact the risk of fracture. With sulfonylureas, there is conflicting results, but I think the risk of hypoglycemia with sulfonylureas does impact the risk of falls and the increased risk of fracture. With GLP-1 receptor agonists, there isn't enough data. DPP-4 inhibitors seem to be neutral, but our new blockbuster drug, which we all are talking about, there is again conflicting data. There's some data which suggests there's an increased risk of fractures, some data which suggests it's neutral. And I think time will tell us what is the long-term impact of SGLT2 inhibitors on the risk of fractures. Insulin, of course, because of the risk of falls, hypoglycemia will also increase the risk of fractures. So not only must we look at whether it is type 1 or type 2 diabetes, we should look at what are the associated features like celiac disease, rheumatoid arthritis. We have to consider autoimmune inflammation, chronic inflammation because of adipocytes, as well as the impact of anti-diabetic drugs on bone metabolism. So I had a lot of help from a host of review articles and original work that I had, which I referred to. So to end my presentation, I will just reiterate my take-home message. Yes, there's definitely an increased risk of fractures, but we must also remember delayed fracture healing. Type 1 diabetes is disproportionately affected, and now we know that in type 1 diabetes, because the peak bone mass which is accrued right at the time of puberty is lower, as well as because of the lack of insulin and its anabolic effect on bone, that affects and increases the risk of type 1 diabetes patients having a fracture. Type 1 diabetes patients have about 5 to 6 times increased risk of fracture as compared to the general population. In type 2 diabetes, again, the risk of fractures is increased. In type 2 diabetes, we must take into account the effect of medications that we use for the treatment of diabetes. We're clear that bone mineral density, of course, is very important to ascertain fracture risk, but we must remember that bone mineral density assessment alone underestimates the risk of fracture, and the risk of fracture in people with diabetes is disproportionately elevated. There is a direct effect of glycemia, not only on the collagen and the cross-linking of collagen, not only on the bone mineral density, but there's a direct effect on osteoblasts, on mesenchymal stem cells, and the bone marrow adiposity in type 2 diabetes. We must always remember the associated conditions which go hand in hand with type 1 diabetes, and we must now henceforth think of skeletal deterioration as one more complication of diabetes that we must always take into account. Thank you so much.
Thank you, Dr. Tejal, for that beautiful summary of the impact of diabetes on bone health, and thank you for reiterating the take-home messages. I think it's quite clear. We'll now hand over to Dr. Jayashree Gopal to take us through the assessment of bone health in individuals with diabetes and briefly present the treatment options that are available. Over to you, Dr. Chitra.
Thank you. So I'm going to be talking predominantly about management. Dr. Nitin is going to be touching upon methods of assessment and 1 minute. Sorry, I'm just trying to share my slides. Yeah. Very briefly in the next few minutes, and I have turned my timer on, I'm going to be talking about management of osteoporosis in people with diabetes. And is it different? I think we had a good lead-in into this topic with Dr. Tejal's talk. And before I start, I would like to thank Dr. Neeta and the organizers for inviting me to IDEC this year. And very happy to be sharing the platform with very illustrious speakers and very good friends. Thank you. So when we look at the management of osteoporosis in general, I just want to talk about this, little slide, one slide. Any person who presents with either osteoporosis or a history of fragility fracture or a high probability for a fracture, I think one of the most important things as endocrinologists we need to do is to evaluate for causes of secondary osteoporosis, make sure we address the calcium and vitamin D deficiency, and recommend pharmacological therapy. I'm not going into detail about this, but if they have a very high risk or a prior fracture, the recommendations are slightly different from if they've not had a prior fracture. This is not the purpose of the talk, but one of the things I did want to mention was after we start the specific therapy, whether we're going to be using the bisphosphonate or whether we're going to be using biologics like denosumab, we do need to reassess yearly for the response to therapy. And depending on the type of therapy that is used, so if you're going to be using bisphosphonates, then at the end of 5 to 6 years, it is recommended that we give a break and assess therapy and see if the benefits on bone mineral density is maintained. If you're using biologics like denosumab, then the therapy needs to be continued for as long as we assess that the risk of osteoporosis and fracture is there, which pretty much is going to continue. So this is roughly the therapy that is recommended in all people with osteoporosis or with a high with a history of a fragility fracture. Now, is it any different in people with diabetes? And the brief answer is no. The general management principles are the same. However, what we do need to be aware of is something that Tejal had referred to. It's very important that we consider that managing the blood sugars, getting the glycemia under control and reducing inflammation is as important as the specific anti-osteoporosis therapies in terms of reducing fracture risk. So ensuring good glycemic control is very important. Regular exercise, as I will show you in a slide, what is consistently turned up in the studies that have looked at osteoporosis and fractures in people with diabetes is that the people with diabetes tend to exercise less, and this itself puts them at a higher risk of not only poorer glycemic control, but also higher risk of a fracture and lesser bone quality. Adequate vitamin D replacement, and what we need to keep in mind in people with diabetes is that a lot of times people who are obese with a high BMI are going to require a higher than normal or higher than recommended vitamin D doses to maintain the vitamin D levels above 30. And there is some association between lower levels of vitamin D in people with diabetes. So ensure that the person with diabetes with osteoporosis or fracture, check the vitamin D, ensure we give adequate, more than adequate replacement. The weight and BMI is what I would consider Goldilocks. You need to have the weight just right. As Tejal pointed out, too low is also bad and too high can be misleading. So if the BMI is high, remember that the BMD estimate that you get can be misleading. So as always, it's important to keep the weight in the correct Goldilocks zone, not only for the diabetes, but also for the BMI and fracture risk. And of course, there needs to be a proper intake of dietary protein and fiber, which also contributes to bone health. So specifically in diabetes, I think one of the most important things is exercise and vitamin D replacement. One of the questions that I had when I was starting to prepare for this talk was, are anti-osteoporosis therapies less effective in people with diabetes? And there is actually surprisingly very little data available, but this was one of the earliest studies that was done using bisphosphonates with diabetes. And when they looked at the subgroup of people with diabetes, a fracture intervention trial, It came out more than about 15 years ago, looking at the effect of alendronate in reducing the risk of osteoporotic fractures. And if you look at the baseline data, what it showed was that the people in the diabetes group were more likely to have had more days in bed. So more likely to have been sedentary, less exercise, with less physical activity. So that itself, a priori, puts them at a higher risk of having a lower BMI and developing a fracture. So this is something we always need to keep in mind when we are treating people with diabetes. If you look at the response of the people with diabetes, women with diabetes responded to alendronate with similar increase in the lumbar and the spine BMD as the non-diabetes group. So that was not, that did not change. And if you looked at bone turnover markers also, they responded similarly in both groups, in the diabetes versus the non-diabetes group. So at first look, it does seem that the people with diabetes respond the same to at least the bisphosphonates. We do not have data with zoledronic acid, which is probably the bisphosphonate that is used most commonly along with alendronate in our country for treatment of fractures. There isn't a subgroup analysis that I could find looking at zoledronic acid. There is some data with denosumab. So they took a subgroup of people from the big trial with denosumab, which was the Freedom trial. And out of the total number of people in that group that was treated, which was 7,800, they took about 500 people with diabetes and they did a subgroup analysis. And what they showed was that the improvement in the lumbar BMD, in the hip BMD or the femoral neck BMD was not different whether we looked at the group with diabetes or the group without diabetes. So at least in terms of the improvement in the bone mineral density, there is no difference. And that has to be reassuring for us in people with diabetes as compared to non-diabetes. And if you look at the reduction in fracture risk, the reduction for new vertebral fracture was the same in the denosumab group in the people with diabetes as compared to the non-diabetes group. However, the risk of non-vertebral fractures actually seemed to increase in the group that was put on denosumab. So this was a little bit worrying data, but the risk, if you sort of look at the whole non-vertebral fracture group, then the risk of fracture was seen to be increased, but the hip fracture was reduced. So that is again reassuring. And if you look at teriparatide, again, one study which looked at a subgroup analysis, and what that showed was that the risk of reduction of fractures with the use of teriparatide was the same in the people with diabetes after the first 6 months. So with teriparatide, we need to remember that the risk of fracture reduction does not happen immediately. It only happens if we keep them on it and look at the data for more than 6 months. So when we are looking at using recombinant PTH or teriparatide, the duration of therapy becomes important, whether it is in diabetes or the non-diabetes group. The improvement in the bone density was the same in the spine and in the femoral neck, and symptomatic treatment and tolerability was the same, whether it was the diabetes or the non-diabetes group. This systematic review, which looked at the efficacy of anti-osteoporotic medicines in both type 1 and type 2 diabetes, basically the bottom line was that the improvement in the bone density was seen across all of the commonly used anti-osteoporotic therapies. So whether it be the bisphosphonates, the SERMs, or denosumab or teriparatide, the bone mineral density did increase. The risk of fracture was not different from the non-diabetic group. However, the only, it was either the same or it was slightly less compared to the non-diabetic group. So overall, to answer the question that I had posited, are anti-osteoporosis therapies less effective in diabetes? Overall, the answer is no. The only sort of note of dissent that comes is for the non-vertebral fractures with the use of denosumab in the Freedom trial. But again, that was a very small subset of a relatively small population. But I think it drives home the point that Tejal was making, that we need to address inflammation in people, particularly with type 2 diabetes, if you want to realize the full benefits of anti-osteoporosis therapies. And apart from just putting them on the bisphosphonates, we need to keep in mind that we need to prevent recurrent falls. And people who have had long duration of diabetes, that itself is a risk factor for fracture. So people who have had diabetes for 20, 30 years, we need to be extra careful about making sure that we maintain their bone strength. So people who have had diabetes for 20, 30 years, make sure that we give them adequate calcium, adequate vitamin D, make sure that we do not increase their risk for falls. And there was some question in the literature as to whether osteoporosis therapies per se have any effect on glycemic or metabolic control. And the brief answer is no. I'm not going to talk about this. But I do want to talk about this a little bit. Do we need to modify anti-diabetes therapies after a fracture? If so, how? And again, this is from that review paper, which looked at the effect of the commonly used anti-diabetes therapies on effects on bone mineral density and risk of a fracture. And what we can conclude at the end of it was that metformin, if anything, has a beneficial effect, probably because it reduces inflammation, helps to reduce weight, and because of the glycemic control. So after a fracture in a person with diabetes, we can continue. It may actually have some benefit in helping bone density and reducing the risk of a fracture. Sulfonylureas, you will continue, but make sure that we reduce the risks so that we don't have a hypoglycemic episode, which may lead to a fall. So that is what we need to keep in mind with sulfonylureas, but overall it does not reduce bone density or it does not increase the risk of a fracture. There is no data specifically with alpha glucosidase inhibitors. Probably we can continue with this after a fracture. DPP4 inhibitors, again, shown to be safe. It does not alter BMD. It does not increase the risk of a fracture. We can continue after a fracture. With SGLT2 inhibitors, again, we have to be a little bit careful because with CANA, the initial CANVAS trial did show an increased risk of a fracture. However, with subsequent Credence and the CANVAS-R studies, it did not show any increased risk of a fracture. However, any person who is on CANA, who's had a fall or a fragility fracture, severe osteoporosis, consider if we can consider either changing the SGLT2 inhibitors. DAPA, the trials with DAPA and MPAR did not show any increased risk of fracture. With all of the SGLT2 inhibitors, what we need to be careful is to make sure that they do not fall, so reduce fall risk. GLP-1 analogs may be beneficial for the bone, similar to the DPP4 inhibitors. Certainly, we can continue after a fracture. Insulin, definitely continue, but reduce the risk for a hypos and a fall. I'm just going to summarize now. So the general management principles for management of osteoporosis and fractures in people with diabetes is same as the non-diabetic population. Emphasis is more on glycemic control and reducing inflammation. Always keep in mind whether the medications we are giving is going to cause a hypoglycemia or increase the fall risk, and thereby modify the anti-diabetic therapies after a fracture or after a diagnosis of osteoporosis. I shall stop here and answer questions after all the talks are over. Thank you very much.
Thank you, Dr. Jayashree, for that reassuring talk on management strategies for osteoporosis in individuals with diabetes. And now invite Dr. Nitin Kapoor to talk to us about what the latest guideline tells us about diabetes and bone health. Over to you, Dr. Nitin.
Thank you so much, Chitra, and thank you, Dr. Neeta, for this kind invitation. It's always good to be back at IDEC. I remember about 2 years ago, Dr. Chitra and myself did a workshop on osteoporosis at IDEC in Pune, and I think it was very well attended. And ever since, the flyer for this particular masterclass has gone on the social media platform. There has been a lot of interest. I know of colleagues from Australia, China, and a lot of friends from India who logged in for this masterclass in particular. And over the next 7 minutes or so, I shall take you through what do the latest guidelines tell us. And of late, very recently, we have the Indian Society of Bone and Mineral Research who come up with their position statement on diagnosis and treatment of osteoporosis. And this specifically highlighted the important aspect of diabetes as an important risk factor for osteoporosis. So conventional teaching, I think all of us, what we've learned is that there are modifiable risk factors, there are non-modifiable risk factors. In short, we know that an elderly postmenopausal woman is at high risk for developing a risk factor. We know the modifiable risk factor, the vitamin D, the calcium, rheumatoid arthritis, steroids. But today, type 1 and type 2 diabetes have emerged as significant risk factors, and this is well cited in the guideline. But the point that has been highlighted so far is that the bone mineral density may not be as low in people with type 2 diabetes, despite having a high risk of fracture. So how do we go about this assessment, even though they are at high risk of fracture, but the BMD does not tell us the truth? And when we look at the other guidelines, and this is by the American Society of Bone and Mineral Research and the ISCD, these guidelines again published this year in April 2021, and their statement is that we should not look at BMD alone, but look at something called a trabecular bone score in people with diabetes, and that will tell us the actual truth. So what is TBS? It's basically nothing very fancy, something that comes out of the same DEXA machine that we use for BMD. It's just an additional software, no extra time. It can be retrospectively recruited from the BMD images. And when we look at the cutoffs, what we know is a value which is less than 1.2 is considered as degraded bone microarchitecture. So is there data with respect to that from India? And we recently published data in about 200 postmenopausal women with type 2 diabetes from our center. And what you can see in this slide is that the BMD in people with diabetes, in women, postmenopausal women with diabetes, is similar, or rather even higher in people with diabetes, but the trabecular bone score is much lower. About 33% of these women had fracture, but 50% have low TBS. So TBS is an important marker. Trabecular bone score is an important DEXA tool that we can use to assess the true aspect of bone health. Yes, hip structure analysis is another way, but that's not very commonly available. Something called as buckling ratio. If it is high, it tells us poor bone health. But yes, do not look at BMD alone. The fracture risk is high, and trabecular bone microarchitecture is something that helps us. So what if we change our gears and we were talking so far of a person with diabetes coming to our clinic and we are evaluating for osteoporosis, but what if a person with osteoporosis comes to the clinic and we need to evaluate that patient? And yes, we always ask for calcium, phosphorus, we ask for vitamin D. But today in the ISBMR guidelines, inclusion of glycemic status has also been written as something that is part of secondary osteoporosis evaluation. So if you have an elderly patient with osteoporosis, yes, you evaluate everything for bone. Yes, you're supposed to screen probably everyone in that age for diabetes, but specifically for secondary osteoporosis, you can do that. The common way that in clinic we assess osteoporosis is using the FRAX, but here again, there's a setback. And this is the ACE guidelines again published in May last year. And they have told that the FRAX also probably underestimates the fracture risk. And therefore, the FRAX has a facility to incorporate the TBS value. And if you have that, probably that will help. But more recently, literature is suggesting that we can change the FRAX in a way that we can use it for people with diabetes. How do we change FRAX? Now, if you remember, the FRAX has several risk factors. One of them is rheumatoid arthritis. It has been suggested to replace the rheumatoid arthritis with diabetes. FRAX, when we add TBS, tells us the true value. When we and that will tell us the right risk, or we reduce the age that we are entering in FRAX by 10 years. Yes, the ISBMR guidelines has taken note of that. And today they suggest that we should start treatment in people with diabetes. If you're not even looking at FRAX, just a T-score, not at -2.5, but at -2, at a lower threshold. And similarly, treatments like we always know that people who are taking steroids, we need to treat them for osteoporosis while their osteopenic. Diabetes has also been included as an important risk factor to consider for treatment when they already have osteopenia or low bone mass. Talking about treatment, Dr. Jayashree did mention very nicely, yes, we have to avoid certain anti-diabetic agents. Some are beneficial more than the others, but a very recent ECNA article on treatment of osteoporosis tells us that there is more data that is required in this field. Recently, in the Trendo conference, which was led by Dr. Jayashree, there was an interesting poster from JIPMA, which looked at the zoledronate effect on people with diabetes. And so, yes, there is data emerging, but as of now, by and large, the treatment remains the same. In conscious of the time, I think I'll stop here and we'll take questions. Thank you.
Thank you so much, Dr. Nitin, for being sensitive to the time constraint. But if I can quickly ask you a question, how do I source the software to calculate the TBS score on my DEXA machine? Is it compatible with all DEXA machines?
Right. So it depends on the kind of machine that you have. We need to contact the vendor. So we use the Hologic machine here in Vellore, and Hologic does provide the TBS software. It needs to be incorporated in the same machine. It's nothing very fancy, nothing very big, can be done in most machines.
And what is the cost like, Dr. Nitin?
Right. So cost would vary again based on the model that you have, but yes, it is costly to the scale of around 5 to 10 lakhs, depending on the machine.
Okay, all right. Thanks for that bit of information. If I can ask Dr. Jayashree a question. So the guidelines do recommend that we change the T-score cutoff to -2 in individuals with diabetes. Have you been implementing that in your practice, ma'am? And what are your thoughts on that?
Actually, I was going to ask Nitin that question. I have not. Honestly, I have not. And I think it is about time we do it. I should start doing it. I have not really been doing it. We're just so used to, as you know, looking at the bone score from the -2.5 aspect that. And what do you think, Nitin? Is it time that we start doing that?
Yes, I think we've started doing it off late, and I think it makes a huge difference for those patients because the fracture risk is definitely high. And I think what has been said in all the 3 talks, I think what I really want to highlight is that the bone fragility is just one aspect in diabetes. We have to look at the big picture of complications, risk of falls, retinopathy, neuropathy, and all that adds up as a big misery. So I think we should.
Okay. If I can ask another question to either of my experts, when we looked at the cascade of management of osteoporosis, Dr. Jayashree, in the slide, you would broken them down into very high risk and high risk, right? And then the treatment protocol was different. So on what basis do we do that segregation?
So that's just partly to do with the T-score. When the T-score is very high, then we consider it a very high risk. Or if a person has had a fracture with a relatively normal T-score, then that also puts them at a high risk. So what we call a fall from a standing height. So someone who just say trips over in the house and falls. So every time a person comes in and says they have had a fracture, the question always should be, how did you get the fracture? So if they say, I just fell from some of them, they just fall down from 1 or 2 steps and they had a fall. So a fall which normally should not cause a fracture, but causes a fracture is for me, a consideration for a fragility fracture, among other things. So these 2 are the most common ones that we see in the clinic, either a very high T-score or a fracture after a fall from a standing height.
All right. So Nitin, inputs any different from Dr. Jayashree's?
No, I concur completely.
Perfect. So I have 15 seconds and I'm going to attempt to summarize. Diabetes and osteoporosis are both silent illnesses and they increase in prevalence with age. We have understood the relationship between diabetes and its effects on bone health by itself. There is a recommendation to reduce T-score cutoff to -2 in individuals who have type 2 diabetes. There's also a recommendation to add trabecular bone score to your diagnosis methodology when you're using your DEXA machine to assess for osteoporosis in individuals with type 2 diabetes. And of course, treatments which are available for management of osteoporosis are just as effective in individuals with type 2 diabetes. And thank you so much, IDEC team. Thank you, my stellar speaker. And I hand back over to Dr. Neeta Deshpande.
Thank you. Thanks, Chitra.
Hello. Thank you so much, Chitra, Dr. Nitin, Dr. Jayashree, Dr. Tejal, for this wonderful subdivision of the topic, wonderfully coordinated EBM masterclass, and a very wonderful and precise message to be taken to the clinical practice. Thank